So, good afternoon everybody, and welcome to this fourth webinar promoted by the European Society of Cardiac Radiology. My name is Marco Francone from Rome, and I will be the moderator of this exciting session today dedicated to dilated cardiomyopathy. The title is Approaching Dilated Heart, Is It Only a Matter of Tissue Characterization? And we have a very distinguished and prominent figure of our society, which is Dr. Charles Peebles, who is a consultant radiologist working in Southampton, honorary senior lecturer in this university and highly experienced in cardiac imaging. So we will share our experience in the next roughly 1 hour of lecture. And again, as we already discussed in previous webinars, feel free to interact with the platform. I'm able to read questions. If possible, in any technical problem, I will be able to interact with you, and we are here to listen to this very hot topic of cardiac MR or cardiac imaging in general. So Charles, welcome, and let's start.
Thank you very much, Marco, and thank you very much for the invitation to join your distinguished list of webinar speakers. And welcome to you guys this afternoon for listening to this. I've been asked to talk about my approach to dilated hearts, and is it only a matter of tissue characterization, which is a great topic to talk about, because dilated hearts are one of the commonest referrals we get to the cardiac imaging service, predominantly for MR, of course. So what I'm going to do is talk to you for about an hour about my approach to this. First off, I want to talk about tissue characterization and what I or we mean by tissue characterization. When I started doing cardiac MRI, which was 25 years ago, we were limited to what we would consider the standard tissue characterization type sequences, so turbospin echo, T1, T2 weighted imaging, which of course had a great role in showing things like scar in this patient with fatty metaplasia here. But we were quite limited. And then in the 2000s, there was the major advance of late gadolinium enhanced imaging, which was predominantly designed to identify myocardial scar in the context of ischemic heart disease, such as here. But of course, we found out quite early on that the pattern of scar was very helpful in differentiating cardiomyopathies of all sorts and didn't just apply to ischemic heart disease. So that was a major breakthrough. And we could see atypical patterns of scar in other disease processes. And then much more recently, and very excitingly, we've had the advent of tissue mapping techniques. And these have not only added some color to an otherwise somewhat black and white world, but they've really added advances in how we look at the myocardium. So we have native T1 mapping techniques, which look for diffuse fibrosis, edema, and potentially fat. If you add contrast to that equation, we can look at ECV, extracellular volumes. We have standard T2 mapping sequences looking at edema and potentially myocardial hemorrhage. And then there are T2 star mapping techniques, which we've used for a long time to look at iron loading in the myocardium. So a whole raft of new and interesting techniques that allow us to look at tissue characterization. I'm going to talk about causes of dilatation generally, and the first thing I want to address is what causes dilatation of the heart. So here we've got in the top left of your screen a normal looking heart and an abnormal dilated heart. What processes take one to the other? And the first one of these is volume loading. So any lesion that causes increased volume in a cardiac chamber will cause it to be dilated because it has to have a bigger stroke volume in order to maintain a balanced circulation. So volume loading is probably one of the most important causes of ventricular dilatation, and I'll talk about that more as we go through the talk. The second area of abnormality is myocardial disease itself. So there's a disorder of the myocardium, there's ventricular failure, and that is of course where all the cardiomyopathies lie, and that's the second big area. The third area is pressure loading or afterload. And of course that doesn't go directly to LV dilatation, it goes via a phase of LV hypertrophy with a thickened heart, but not usually chamber dilatation. And chamber dilatation occurs when the ventricle has started to fail. So those are our three broad areas that will cause ventricular dilatation. I'm going to divide this lecture essentially into two, and I'm going to start talking about the right ventricle first, and then we'll talk about the left ventricle later. The reason I'm doing that is that causes of right ventricular dilatation are somewhat different to those of left ventricular dilatation. So my emphasis here is going to be much more on structural heart disease. And you'll see that the causes of right ventricular dilatation include left to right shunts, such as ASDs, partial anomalous pulmonary venous drainage, and valvular regurgitation, tricuspid and pulmonary regurgitation. Now, the importance for cardiac cross-sectional imaging here is that echo, whilst great at looking at tricuspid valve and pulmonary valve disease, is not necessarily good at identifying ASDs and partial anomalous pulmonary venous drainage. Specifically, sinus venosus ASDs, the ones that lie up underneath the SVC or down near the cava, are easily missed on TOE and transthoracic echo. So one of the commonest indications we get for MR is cause of right heart dilatation. So what's my approach to that? So here are four cases for patients with right ventricular volume loading. And what I want to do is just highlight the features that we see in a volume loaded ventricle. And it doesn't really matter which one of these cases you look at. Perhaps if we look at this one here, you'll see the features nicely. So the first thing you see is right ventricular dilatation. This is quite subjective in a four-chamber view. The next thing you'll see is that there's interventricular septal flattening. You can see this abnormal wobble here over the septum, and this occurs early in diastole, and that's a typical feature of volume loading of the right ventricle. We can see that in most of these cases there's well-preserved function, and that's typical until there's end-stage disease and the ventricle starts to fail. And importantly, there is no right ventricular hypertrophy. Again, that's a slightly subjective finding, but there's no obvious right ventricular hypertrophy. So the ventricle actually itself looks quite normal, the free wall looks quite normal. So these are the typical features we see of RV volume loading. How are we then going to differentiate the four cases? Well, this comes down to structural analysis. When you look at the four-chamber view here, you can see that the interatrial septum here is aneurysmal. There may or may not be an ASD. It can be quite difficult, and the atria can be naturally quite thin, but you'd be suspicious about there being an ASD here. The short axis view shows RV volume loading as we expect. And if you extend that up, you'll come onto the septum, and again it looks aneurysmal, and there's probably a defect in the septum. I put in a black blood image here of the pulmonary artery compared to the aortic size, not because it's a very good example of pulmonary dilatation in this context, but because it reminds me to talk about it. One of the consequences of RV increased flow is that you get increased flow through the pulmonary artery, which then dilates. And I think you can probably appreciate in these flow images that the pulmonary artery looks a little dilated. One of the bugbears that I have about the shorthand that radiologists can use when they're looking at cardiac structure is to say that a dilated pulmonary artery equals pulmonary hypertension. And that is wrong. It can mean that the patient's pulmonary hypertensive, but very frequently, in fact more frequently than that, it just reflects increased pulmonary flow, and it does not indicate pulmonary hypertension. So if you see pulmonary artery dilatation, don't automatically say that there's pulmonary hypertension, because that's not the case. Any left to right shunt lesion will cause it. So to confirm our suspicion there's an ASD, we're going to do standard phase contrast imaging through the aorta and pulmonary artery, and you can see that the pulmonary artery flow is greater than the aortic flow. And if we quantify that, we've got a QPQS of 2.4 to 1, so a significant size shunt. We could, of course, do several other techniques to try and identify the ASD more clearly. We can do a long axis through the atrial septum here and do flow through it, and we can measure the ASD and directly quantify transseptal flow. The second case I showed you at the beginning is this one. This is a little easier because we can see the cause of the RV dilatation as soon as we look at the four-chamber view, and there's tricuspid regurgitation. There's some annular dilatation. Interestingly, or importantly, the hinge point of the tricuspid valve is relatively normally positioned, and the posterior leaflet of the tricuspid valve also looks normally positioned, as opposed to Ebstein's anomaly, which we'll talk about later. You can see a broad and complex jet of TR and a well-functioning but dilated right ventricle. So we can quantify this. We can look at the actual tricuspid regurgitant area there. We can look at flow. Now, quantifying tricuspid regurgitation is difficult. You can put a flow, phase contrast flow map through the tricuspid valve and look at the retrograde flow here and the forward flow, and we can quantify that. But actually, in most cases of tricuspid regurgitation, the tricuspid regurgitant jet is so complex that it's very difficult to do that and capture the whole regurgitant jet accurately. So more traditionally, we do a standard RV volume analysis, and we assess RV stroke volume, and we then subtract the pulmonary flow from that, or and that should give us the differential flow between the pulmonary artery and the stroke volume, which is the tricuspid regurgitant volume. That works well, of course, as long as there's not pulmonary regurgitation as well. So this is a dysplastic tricuspid valve with tricuspid regurgitation. You can see the morphology of all of these hearts is very similar, and it's important we interrogate these properly. So this is a patient who has a dilated right ventricle, volume loaded. You can see the typical early septal flattening and bounce. And in this patient, there's no pulmonary valve or tissue. In fact, the outflow tract here is akinetic. And I haven't told you, but clearly this patient's had a traleger fallow repair, and they've had an outflow tract patch and transannular patch, which has resulted in free pulmonary regurgitation. We can again quantify pulmonary flow in the standard way and look at the volume of regurgitation, which is significant. And the final case, not so much RV dilatation, but it is big, certainly on quantification it's big. So we're going to hunt for the cause for this, and our transaxial black blood sequence is from a haste stack, so low resolution. We'll show again a big pulmonary artery, not necessarily hypertensive, but large, indicating high flow. We can see here that there's an abnormal vessel lateral to the mediastinum, and on our contrast-enhanced MR angiogram, you'll see that there's pulmonary drainage of the left upper lobe. There's a normal left lower lobe pulmonary vein, but a left upper lobe partial anomalous pulmonary venous drainage. And the QPQS here is 1.8 to 1, perhaps slightly larger than you anticipate, but actually we usually find that although only a quarter of the lung is anomalously drained, we get a larger shunt than we expect. So in Southampton, our basic scan protocol for the dilated RV includes what you'd expect, which is a localizer. We then do a full stack of fast black blood sequences, or you can use a white blood sequence if you prefer. And this shows us our vascular connections. It will show you the partial anomalous venous veins, etc., etc. We then do standard SSFP CINES in both the standard cardiac short axis and long axis planes, but we also do an axial RV stack for our right ventricular analysis. Now the reason for this, so when I talk about an axial RV stack, this is what we're doing. We're going to do a stack from the RVOT down to the base of the heart, and we analyze it in the standard way. We prefer doing this for the RV analysis over a short axis RV analysis, because although there's a slight difference in volumes produced and the short axis volumes are slightly bigger than the transaxial volumes, we find that the transaxial data set gives us a much better intra and inter-observer variability. And there are about 5 of us who report MR, and it helps with our reproducibility, particularly in congenital heart disease. So once we've done our RV analysis, we'll do phase contrast flow mapping, typically of the MPA and aorta, but usually we include the branch PAs as well. That's not strictly necessary, but we find it provides a useful internal correlation. If the branch pulmonary flows match up to the MPA flow, we're much more confident about quantifying pulmonary regurgitation, for instance, or degree of shunts. When we talk about shunts, we don't usually consider someone with a QPQS of less than 1.2 to 1 as significant. So small variations in pulmonary and aortic flow are very common. We don't consider them to be important until they're up to 1.2 to 1. We then do targeted imaging. This might include MR angiograms, for instance, with your patient with partial anomalous pulmonary venous drainage. We might want to hunt specifically for an ASD. And that's one of the other advantages of doing a transaxial RV stack, because it actually gives us another view through the interatrial septum. We might want to do T1, T2 weighted sequences and mapping, and we may want to do late gadolinium enhancement, particularly if we're looking for ARVC. Most of our studies are performed unsupervised, so we tend to put all of these into our protocol or allow the radiographers to make a decision about what scan sequence to use. If you're supervising your scans, obviously you can make those decisions on the hoof. Now, so far I've spoken about MR, but of course the same findings apply to CT, and this is a common problem we find in, for instance, CT pulmonary angiography, and we not infrequently will find a dilated right heart, and it's an area that our registrars often need some education in because it's quite difficult. So here is a patient with a dilated right ventricle, and you can see here that the coronary sinus is dilated, which might be relevant or it might not be relevant. If I start at the top now, you'll see an abnormal vessel lateral to the left pulmonary artery. That's actually a persistent left SVC, which is draining to the coronary sinus and isn't relevant in this particular case. But as we go down, we can see partial anomalous pulmonary venous drainage of the right upper lobe here onto the back of the SVC. And when you see partial anomalous pulmonary venous drainage, as you all know very well, we need to exclude sinus venosus defects. And here is a typical rather tunnel-like sinus venosus defect. So it's communication between the sort of SVC-RA junction and the left atrium here. So we've got a full house of partial anomalous pulmonary venous drainage and sinus venosus ASD. And it's very important that whenever you see a right heart that's dilated on CT, you interrogate the anatomy carefully so we don't miss ASDs and other shunts. So the next phenotypic process we need to go through, morphological process we need to go through, is differentiating the RV volume loaded chamber and the pressure loaded chamber. So on the left you'll see typical volume loading, which we've already seen. In the middle we can see a halfway house. During systole, this right ventricle looks a little bit thickened. It's not particularly dilated, and particularly on the short axis view you can see that actually the right ventricular free wall here is approaching the left ventricle in terms of thickness. And look at the interventricular septum. It doesn't have that early diastolic flattening. Actually, it seems to be throughout the cardiac cycle that the septum is a little bit flattened. And this is a patient who started to develop pulmonary hypertension. If I show you a much more gross example, this is a patient with the most advanced form of pulmonary hypertension, which is a systemic right ventricle. So this patient's got a mustard for a transposition, and this is a systemic right ventricle, and you can see that it's very hypertrophied, and the septum is bowed, so it's committed to the right ventricle, not the left ventricle. And that's the typical appearance of systemic RV. So you can see there's a big difference between this and the volume loaded right ventricle, and that's a really important differentiation to make early on in this assessment of RV dilatation. So this is the same case I showed you in the middle, and it just shows you the importance of thinking through the process. This is actually a 4-year-old child who presented with an echo showing RV dilatation, I think an innocent murmur. I can't remember the exact cause, but the echo showed RV dilatation. And unfortunately, this was missed at the referring hospital. And if you look at this central image, which is the one you've just seen, you can see this concentric right ventricular hypertrophy with septal flattening. You can see a big PA. So we really need to hunt for causes of this. And if you look at flows, there is no evidence of a shunt. So the MPA and aortic flows are essentially the same. as are the LV and RV stroke volumes. So there's no clear shunt. So why has this patient got a dilated RV, dilated PAs? It could be, of course, they've got primary pulmonary hypertension, and that's a diagnosis of exclusion. But in fact, when you look carefully, this is the PA flow done to look at the pulmonary valve. You'll see this is the LPA. What's this structure here? And then you look back at a branch PA flow, and again, there's an abnormal structure here communicating between the descending aorta and the LPA, and this is a PDA. So why don't we have a bigger shunt? Why isn't the aortic flow higher than the MPA flow? And the reality is the patient's developing Eisenmenger syndrome. So there is no flow because there's no gradient across the pulmonary, aortic to pulmonary valve. Okay, so those are our volume loading lesions of the right ventricle. The second group of diseases are those affecting the right ventricular free wall and right ventricular cardiomyopathies. And there are three of those I want to talk about. The first one is well known to us, ARVC, as you know, characterized by fibrofatty replacement of the right ventricle, a common cause, unfortunately, of sudden cardiac death in young patients. It's a progressive disease with variable genetic inheritance. The etiology ultimately is unknown, and it is difficult to diagnose clinically, and there's a big issue relating to family screening because of its genetic inheritance. You'll be very well aware of the task force criteria from 1994 for diagnosing ARVC, which suggested major and minor criteria, including severe dilatation and reduction of RV function, localized aneurysms, segmental wall motion abnormalities, and then minor ones which were considered minor RV dilatation, reduction in ejection fraction, etc. Tissue characterization was considered as part of these criteria, but not as an imaging finding. It was considered as part of a biopsy process rather than an imaging process. So these were updated a while ago now, and very helpfully, because they've actually now given us quantification of what we consider major. So rather than just major RV dilatation, we're now talking about RVA kinesis, dyskinesis with one of the following. So an RV end diastolic volume related to body surface area of greater than 110 for a man or 100 for a woman, ejection fraction of less than 40%, and then slightly lower criteria for minor criteria, as it were, with a right ventricular end diastolic volume of between 100 and 110, and slightly lower for women with a slightly better ejection fraction. So really helpful quantifications now been added. So your typical patient with ARVC is quite easy to diagnose. This patient has a markedly dilated right ventricle, very abnormal trabecular pattern, very abnormal wall motion, to tricuspid valves in the right place. So this is an Ebstein's, so severely abnormal right ventricle, and that's going to fulfill the criteria for diagnosis. Of course, many of these patients have very poor gating because they have frequent ectopics, etc. So here, this is a typical sort of black blood sequence with rather poor resolution. Late gadolinium enhancement is common and can be diffused through the right ventricle, and also involve the left ventricle in those cases where there's LV involvement. And about 70% of cases in this series showed some sort of scar over the right ventricle, whereas in the control cohort there was no RV scar. And there's some suggestion that the extent and pattern of scar also might predict prognosis. So ARVC in an easy case is easy, but unfortunately there are many pitfalls in the diagnosis. This is a patient who was presented to us with RV dilatation on echo, query cause, and you can see that the RV is indeed big, as is the right atrium. Function is quite poor, particularly around the inferior wall here. And more distally, function remains poor. So undoubtedly this patient fulfills the major criteria in terms of wall motion abnormality and dilatation of the right ventricle. But do they have ARVC? Those of you who are observing carefully will notice there's some thinning of the inferior wall of the septum here. when we look at tissue characterization sequences, fairly typical. We can't really determine whether there's much fatty infiltration here. But late gadolinium enhancement, you can see there's quite a lot of scar over the RV-free wall. But it also comes down over the inferior wall of the RV and onto the inferior septum where that little wall motion abnormality was. So is this ARVC with some LV involvement, or is it something else? And in fact, on angiogram, the patient has an occluded RCA, and I think it's probably all right coronary territory scar with a free wall infarct. So everything that looks like ARVC is not ARVC. But just to reassure you, some cases are quite easy. This is a beautiful case. This is a family member of someone, a first-degree relative of someone who died with ARVC, and you can see clearly fatty infiltration, abnormal wall. There's a patch of scar, and there's a nice dyskinetic area here. So that's not going to be a challenge. But ARVC does remain one of the most difficult diagnoses I think we have to make. Uhl's anomaly, this is very rare. I've seen one case, but I couldn't find it, so I've had to nick one off the internet. So this is a diagnosis described in the 1950s with complete muscular absence of part of the RV-free wall. So there's an epicardium and an endocardium, but there's no muscle between the two. And this group from Bob Anderson in London compared that with ARVC and pointed out the salient differences. They both have normal tricuspid valve, but in Uhl's anomaly, the septum is not involved. Importantly, there is no fibrofatty infiltration. This is not a fibrofatty process. This is just an absence of muscle. The Uhl's anomaly patients present much younger, and usually they present with heart failure, stroke, etc., not arrhythmia, which is more typical for the ARVC patients. So they're quite a distinct spectrum of patients, but it's worth thinking about in the younger cohort. And finally, as part of the RV cardiomyopathy process, I've included Ebstein's anomaly. You may say, well, actually, this is just a valvular abnormality involving the tricuspid valve, which indeed it is, of course. So the main features of Ebstein's are failure of delamination of the septal leaflet and the posterior leaflets. So the septal leaflet's stuck against the septum, as is the posterior leaflet. That causes offset of the tricuspid annulus by at least 8 millimeters per meter squared. It causes an atrialized portion of the RV here. And there are a number of other features, including a redundant fenestrated anterior leaflet, dilatation of the AV junction, unsurprisingly. And more recently described, there's a rotational abnormality of the valve orifice, which I'll show you in just a moment. But it's also become clear that there's a myocardial involvement to this, and actually it's a global process, which is why I've included it as part of the cardiomyopathy discussion. There are a number of associated malformations and features which aren't terribly important to us now. So this is a severe Ebstein's. You can see the features you saw on that pathological specimen. So there's the atrialized interventricular septum. There's offset at the tricuspid valve leaflet down to here. The anterior leaflet is very redundant and large and extends up into the outflow tract. There's lots of trabeculations and septal attachments here to the RV-free wall, muscular attachments, which are very abnormal. So the whole anterior leaflet is tethered to the RV-free wall. You can see huge volume loading. And this is the rotational abnormality I was talking about. This is a long axis view through the right ventricle, and you can see that the outflow of the right ventricle points towards the pulmonary valve. You can see it on FAS here. So the valve plane has gone from pointing into the right ventricle to pointing out towards the pulmonary valve, and that's the rotational abnormality that's also now well described in Ebstein's. And here's late gadolinium enhancement, and you can see that there's quite extensive subepicardial scar over the interatrial septum and probably over the RV-free wall, again confirming that this is actually a myopathic process as well as a developmental structural abnormality. So I haven't really spoken about T1 mapping as yet, and the reason for that is that actually T1 mapping of the right ventricular free wall or septum is very difficult because it's so thin. But there are a couple of studies recently that have successfully done that. This group looked at 24 healthy volunteers, and they managed to show RV ECV was feasible in all patients at 3T and the majority of patients at 1.5T. So perhaps we can use it. And this group looked at 100 patients with non-ischemic cardiomyopathy. And there was a good correlation between the LV and RV T1 mapping values post-contrast. And they also showed that those with the worst T1 mapping values, RV post-contrast, showed the worst outcomes. So they had no functional improvement. And in fact, they showed deterioration. So perhaps some early evidence that we can use T1 mapping for the RV-free wall, and it might have some prognostic information. Okay, so we've covered structural abnormalities of the right ventricle and cardiomyopathies of the right ventricle. We're going to move to the left ventricle now and structure the lecture in the same sort of way. Clearly, volume loading lesions of the left ventricle are best assessed with echo. So mitral and aortic valve disease is really well seen. Unlike in the right heart, it's really well seen in the left heart, as are VSDs and to a lesser extent PDAs. So I'm not going to talk about those in any great detail, but I do just want to talk about the physiology of the VSD in this context a little bit, because certainly my registrars don't quite understand why a shunt lesion causing increased pulmonary flow should cause left ventricular dilatation. And I just want to clarify that for those who maybe don't understand that fully. So this is your VSD. My red arrow is the increased flow. So this isn't just standard, this is the flow through the VSD that's then going to enter the pulmonary artery and return to the left atrium. Now this is the difference between an ASD and a VSD. So in an ASD, this increased flow returning to the left atrium will cross the septum, atrial septum, into the right ventricle and be discharged into the pulmonary artery. In a VSD, of course, it returns to the left ventricle. So the left ventricle is seeing increased blood flow returning and increased ejection fraction. So it's the left ventricle that does all the work to accommodate the extra flow through the VSD, not the right ventricle. And that's the slightly this confusing thing about flow. So this is a case, just to illustrate that, this is a VSD. Quite typically, you can't see it on the 4-chamber view or 3-chamber view, but in the short axis view, you can see a typical perimembranous VSD. Looks quite restricted. A lot of flow acceleration is probably being partly restricted by tricuspid valve tissue. So if we look at our aortic and MPA flows, our aortic flow is 106 mils, our MPA flow 180 mils, gives us a shunt volume of about 75 mils, QPQS of 1.75 to 1. So we've got increased pulmonary flow, that's no great surprise. If we look at the LV and RV analysis, we've got a dilated LV at 250 mils, and the stroke volume through the left ventricle is 190 mils. Look at the right ventricle, we've got a normal sized right ventricle with a stroke volume 104. So that 75 mils of flow is being ejected and supported by LV stroke volume, not RV stroke volume, because the blood essentially comes into the right ventricle during systole and straight out, so it's just acting as a conduit. It's not actually accommodating that blood flow. So I hope that makes sense. So I'm not going to talk any further about volume loading of the left ventricle. I'm going to go straight on to talk about cardiomyopathy. And this is the area where tissue characterization really does start to come into its own. So cardiomyopathy, I tried to look for European results for this, but I couldn't find any easily. So these are the UK data, about 900,000 people in the UK living with heart failure, and 1 in 15 people over 75 will have some heart failure. The majority of these have ischemic heart disease, but a substantial proportion have non-ischemic dilated cardiomyopathy, and it's a big financial burden to the NHS. Accurate diagnosis is critical, both for management and prognostication in cardiomyopathy. And clearly the echo is the primary tool, but increasingly MR is used. So there's classification of cardiomyopathies has just subtly changed recently. You'll be aware of the WHO classification, which suggests they should be divided into hypertrophic cardiomyopathies, dilated cardiomyopathies, and others such as restrictive cardiomyopathy, ARVC, and unclassifieds. But the European Society of Cardiology recently suggested an advance on that, which was to subdivide these phenotypes into those with a genetic predisposition or a familial predisposition from those without. They classify cardiomyopathy as a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular heart disease or congenital heart disease. So those structural things we've already talked about. If you look at European data, this is data collected over a number of centres in Europe, published recently in European Heart Journal. They looked at 1,000-odd patients presenting with dilated cardiomyopathies or cardiomyopathies between 2012 and 2013. A higher than expected proportion of these have a familial trait. And if you look at the numbers here, the biggest number is hypertrophic cardiomyopathy, followed by dilated cardiomyopathy, and then a smaller number for ARVC and restrictive cardiomyopathy, which is perhaps not surprising. If you also look at the second-line investigations they've had, about 50% of patients with HOCM have CMR, 35% with dilated cardiomyopathy, 40% with restrictive cardiomyopathy, etc. So a good proportion of them are having advanced cardiac imaging, but actually I think you could argue that they should all be having advanced cardiac imaging, so I think we should see a step up in that. And this was in 2012-13, so there probably has been already. So there's been a useful article published recently again by the ESC Council suggesting a diagnostic pathway for dilated cardiomyopathy, and they've divided it into 3 stages, which are outlined here, and I'll just zoom up on those for you. So the first stage, you take your patient with symptomatic heart failure, left ventricular systolic dysfunction, and you exclude the things we've already discussed. So we want to exclude coronary artery disease, we want to exclude valvular heart disease, we want to exclude structural heart disease, and hypertension. So all of those things that the diagnostic criteria require. Now, interestingly, they say exclusion of coronary artery disease, do coronary angiography. We know very well, being cardiac cross-sectional images, that actually CMR is extremely good in this context for excluding cardiomyopathy, ischemic cardiomyopathy. If you look for regional wall motion abnormality, myocardial thinning, and then if you look for the typical pattern of late gadolinium enhancement in a coronary territory correlating with the wall motion abnormality, we can be very, very sure that this is ischemic heart disease, not dilated cardiomyopathy. So if you look at dilated cardiomyopathies with coronary disease, between 80 and 100% will have a typical late gadolinium enhancement pattern, allowing you to diagnose ischemic heart disease. If you look at patients with dilated cardiomyopathy with no coronary disease, a lot of them won't have any late gad at all, which is of course helpful because it means that they don't have ischemic heart disease. But about 30% will have some sort of patchy late gadolinium enhancement, but not of the typical distribution of coronary disease. And this study by Asimul et al. Looked at CMR as the gatekeeper for ischemic heart disease compared with coronary angiography. And actually they suggested if you use late gadolinium enhancement in the typical pattern, you had a sensitivity of 100% and specificity of nearly 100%. And in fact, the diagnostic accuracy of CMR was better than angiography. So I think that ESC statement that coronary angiography is the gold standard is probably debatable. So we can easily tell ischemic causes of dilated cardiomyopathy from other causes. And the reason for that is the very typical subendocardial cascade of myocardial damage that occurs. This is important both because it's diagnostic for ischemic heart disease, but it's also going to be prognostic because, as we know, the more transmural the extent of scar, the less chance there is of viability. Now I say this is easy, but I would just highlight 1 or 2 pitfalls. This is an unfortunate 65-year-old man, 4-year-old man, who presented with atypical chest pain. They thought he had myocarditis. He was scanned somewhere else, and they diagnosed myocarditis on this scan, and I'm sure you in the audience wouldn't do. He's got an extensive wall motion abnormality, but it's over a coronary territory, over the anterior wall and apex. the thing that confused them is the pattern of late gadolinium enhancement, because he has subepicardial, apparently late gadolinium enhancement here. And on this short axis view, there's subepicardial late gadolinium enhancement. But when you look at it more closely, you can see that around the edges, that scar is transmural. And this, of course, is microvascular obstruction in someone who's had a very extensive anterior wall infarct involving the LAD and circumflex territories. And he doesn't have myocarditis at all. So this is microvascular obstruction. So it's just something to be borne in mind. Of course, there's much more we can tell about ischemic heart disease than simply is it ischemic heart disease or not, or the pattern of scar. This is a 50-year-old man who presented with breathlessness and dilated LV, query cause. He didn't have angina. And you can see that he's got relatively well-preserved septal function, but large areas of thinning and akinesis over the apex, and areas of hypokinesis elsewhere over the inferior wall, etc. So we're looking at this and thinking this is probably an ischemic cardiomyopathy rather than a dilated cardiomyopathy. We can look at ischemia itself. So here's our first pass perfusion scan, and you'll see that there's very extensive ischemia throughout the septum anterior wall and over the lateral wall as well. So I think there's evidence of diffuse ischemia. Just let that play for you to see. And then, of course, late gadolinium enhancement, which confirms the ischemic pattern of myocardial scar over the anterior wall, the lateral wall, to a lesser extent the inferior wall. Some areas look transmural, but the majority are less than 50%, and you'd be optimistic that there was viability here. And sure enough, when this patient is revascularized, you can see he's got functional improvement in all areas, particularly the anterior wall and septum. So not only do we diagnose him as having an ischemic cardiomyopathy, we've shown the ischemia and we've suggested he's got viability, and they've gone on to revascularize him. So there's a lot more to be added to ischemic heart disease than simply ruling in and out it out as a cause of dilated cardiomyopathy. Okay, so we'll go on to step 2 of the dilated cardiomyopathy diagnostic pathway. So we've excluded structural heart disease, ischemic heart disease, and we can now get on to looking at things where we're better at or we're good at. So there are 3 boxes here that we can look at. The exclusion of other types of cardiomyopathy. This, in this paper, includes HOCM, restrictive cardiomyopathy, peripartin cardiomyopathy, stress cardiomyopathy, non-compaction. Then we can look at infiltrative myocardial disease, so amyloid, sarcoid, hemochromatosis. And finally, miscellaneous causes, which they include neuromuscular diseases, etc., etc. So it doesn't really matter which boxes you put these in, whether you call them other types of cardiomyopathy or infiltrative cardiomyopathy, and I think you could argue about whether non-compaction sits down in miscellaneous, etc., etc. It's not really important. The importance is that we need to try and exclude each of them before we come to a diagnosis of idiopathic dilated cardiomyopathy. And this is where tissue characterization really starts to come into play. It's not just tissue characterization, we need to look at morphology as well, clearly, but the tissue characterization is going to be important here. Now I'm going to go through some of these just as exemplars and to highlight the areas where I think tissue characterization, particularly mapping sequences, are going to become more important over time and where they help currently in clinical practice. So hypertrophic cardiomyopathy, as you know, common inherited cardiac disorder, varied phenotypes with asymmetrical, obstructive, apical, etc. phenotypes. And the diagnosis is usually made on the basis of the morphology and the tissue characterization. But there are difficult cases, particularly early in disease, and also differentiating from other forms of symmetrical left ventricular hypertrophy, such as athletic heart, aortic stenosis, and hypertension. So if we see a typical case of hypertrophic cardiomyopathy with extensive hypertrophy, myocardial thickness well above 1.5 centimeters, some asymmetry here with the lateral wall being relatively preserved, and SAM, systolic angiomotion of the mitral valve with an outflow tract gradient, we don't find that terribly difficult. We can use tagging to show us that that septum is stiff And we can use late gadolinium enhancement to show the typical pattern of scar, but actually we don't really need to do that to make a diagnosis. We might want to do that to try and determine prognosis. So T1 mapping is an adjunct, but in this case it's not actually made a lot of difference. But life gets a bit more difficult here. This is a patient with a family history of hypertrophic cardiomyopathy with sudden cardiac death. And you can see that there is septal hypertrophy, and there's a little bulge over the anterior and basal septum there. And there's partial SAM, but not complete SAM. So in this instance, late gadolinium enhancement does help, because we can see a typical pattern of scar that I think really takes us from an area of not being sure to being quite convinced that this is hypertrophic cardiomyopathy. But when we're trying to differentiate hypertrophic cardiomyopathy from LVH phenotypes, it gets much more difficult. So a wall thickness of greater than 16 millimeters is uncommon, but we do see it in athletes, particularly Afro-Caribbean athletes. So a ratio of wall thickness, diastolic wall thickness to end diastolic volume of less than 0.15 millimeters per mil per meter is highly suggestive of an athletic heart. It's not 100%, but it's highly suggestive. But sometimes we might need to embark upon a period of detraining. Late gadolinium enhancement, as an aside, can be seen in a substantial number of patients with aortic stenosis, and also isn't seen in a large number of patients with HOCM. So late GAD, whilst it might be helpful in differentiating athletic heart, isn't going to be helpful in differentiating other forms of hypertrophic cardiomyopathy. So here's a patient who is a footballer, professional football player, comes for screening with left ventricular hypertrophy and an abnormal ECG. You can see he's got concentric hypertrophy. He's got a slightly dilated heart, which is a good finding. If we look at the ratio of myocardial thickness here to left ventricular end diastolic volume, if I show you the normalized end diastolic volume, it's 112 mils, and the maximum septal thickness is 14 millimeters. So if you quantify that, it's 0.125 millimeters per mil per meter squared, which is lower than 0.15. So that suggests that this is an athletic heart. We can look at late gadolinium enhancement, which is normal, which is reassuring. We can look at other physiological features such as mitral flow, which is also normal, which is again reassuring, but it's not definitive. Now I think this is an area where T1 mapping is already being really helpful and will continue to be helpful. So this is a study looking at about 100 patients with hypertrophic cardiomyopathy, 70 patients with genotype positive but phenotype negative hypertrophic cardiomyopathy, a control group and hypertensive group. And you can see that the T1 mapping values are distinctly separate in these two groups with our confidence bars here. And actually, if you look at native T1 mapping, it was the best discriminator in this cohort compared to LVH and septal thickness, etc., with a sensitivity of 96%, specificity of 98% versus hypertensive heart disease. And if you look at the phenotype negative patients and look at T1 mapping as the diagnostic tool, you can see it's very good. So I think that in that patient we've just seen with the concentric hypertrophy, showing a normal T1 mapping value is really, really helpful, and I find it very useful in that context. The other context it's very useful in is those patients who can't have gadolinium. So this is a youngish lady with polycystic kidney disease undergoing renal transplant assessment with clear HOCM. We can't give a GAD. We look at the phenotype here, and it does look like apical HOCM, and I think you probably would say it was. But actually, when you add in the T1 mapping, which shows the apical T1 value here to be 1,140 milliseconds, I think we can become much more confident about our ability to diagnose this without contrast. Restrictive cardiomyopathy, I'm not going to talk about in great detail. Suffice to say that there's a typical physiology of the restrictive heart with biatrial dilatation, SVC and IVC dilatation, and normal pericardial thickness, differentiating it from pericardial constriction. The two typical ones of these I'm going to talk about are amyloid, which you'll know all about. So symmetrical hypertrophy, atrial wall thickening, a very typical pattern of late gadolinium enhancement with a failure to null the normal myocardium. And if you see all these features, you can be very confident that this is amyloid. So here's a typical case: diffuse left ventricular hypertrophy, very stiff-looking ventricles, thickened RV, biatrial dilatation. And on tagging, there's diffusely impaired wall motion. Here's our TI scout, and you'll see that the TI scout is abnormal. If you start here, you'll see that the myocardium inverts before the blood pool. So the myocardium is already inverted there, and then the blood pool inverts later, and that's typical of amyloid. And here's our late gadolinium enhancement, very diffuse, subepicardial, subendocardial bands involving the base more than the apex, so very typical amyloid. But again, if we can't give contrast, it can be difficult. This is a patient on dialysis who's got LVH. You can see he's got a big pericardial effusion. He's got relatively well-preserved myocardial thickness, systolic function, function, but he's got hypertrophy, both of the RV free wall and the right ventricle. Now what's this? Now ideally we'd want to give contrast, but we can't. But if we do T1 mapping, you can see he's got a very elevated T1 over the septum of 1,000, nearly 1,200 milliseconds. And if you look at this nice review article recently from JCMR, you can see that there's a spectrum of native T1 mapping and ECV with normals here, hypertrophic cardiomyopathy here, but actually amyloid is all the way up here, approaching 1,200 milliseconds. So I think you can be very confident that actually if you're getting T1 mapping values up here, that's going to be amyloid. The other area of restrictive cardiomyopathy that I think mapping sequences have been really helpful for are Fabry's disease, which is probably commoner than we think in the patients we're looking for hypertrophy. Many of them will have late gadolinium enhancement in a typical pattern. But actually the ability to differentiate this on T1 mapping is really, really helpful. So we've got normal patients here with normal values. We've got hypertrophy patients here with areas of low T1 mapping value. And if you look at patients who are LVH positive compared to normal controls, you'll see that there's very little crossover between the T1 mapping values. And a crossover of about 900 milliseconds is going to reasonably reliably, this is mean T1 mapping, is going to reasonably reliably differentiate these two. So I think that's a really helpful advance. Cardiac sarcoid, again, commoner probably in clinical practice than we realize. The MR findings are well described, and I don't think we need to go through those in great detail. But tissue characterization here and morphology again are the hallmarks. So we've got areas of wall thinning and abnormal motion, but these don't confer to an ischemic territory. They're patchy and rather random. And when we look at the late gadolinium enhancement, again, we can see subepicardial, subendocardial, transmural scar. So it doesn't fit one pattern, and this is typical of sarcoid. This is a different patient where we can see nice sarcoid granulomas in the spleen and this rather bizarre sort of zebra type pattern. So anyone with random and bizarre late gadolinium enhancement, think about sarcoid. Non-compaction is another cardiomyopathy that I think is quite difficult. These are deep retrotrabecular spaces. It's a failure of LV morphogenesis. It's got a genetic predisposition, and it usually presents with heart failure and an abnormal ECG. But sadly for us, it's not easy to diagnose. The biggest study so far comparing patients with non-compaction, which is only 7 patients, versus athletes, hypertrophic cardiomyopathy, etc., showed that a non-compacted to compacted ratio in the diastolic long axis view, so measured in this view, of greater than 2.3 to 1 was quite sensitive and quite specific, which indeed it is. And if you see typical patients, it's an easy diagnosis to make. So here we've got non-compaction of the apex, very thickened non-compacted myocardium and a relatively thin compacted myocardium. So that's not difficult. The problem is that if you look at patients, all comers with dilated cardiomyopathy and controls, and these are admittedly using echo criteria, 25%, nearly 25% of those patients with dilated cardiomyopathy would fulfill the criteria for non-compaction, including 5 of the control patients who we know don't have non-compaction, 4 of those who are Black Afro-Caribbeans. So basically, these diagnostic criteria are too sensitive, and we're going to cast many more people into the net of non-compaction who don't have it. So I would beware diagnosing it too avidly. Right, we're nearly at the end, so don't panic. We're getting down to the bottom of our diagnostic cascade now. We're at step 3. We've excluded other causes of dilated cardiomyopathy, so we're now into the idiopathic dilated cardiomyopathy group. Of these, between 20 and 50% will have a familial history, but in that group, only 35% will have genes found. The others, we won't know what the genetic abnormality is. In the non-familial group, 50% no cause will be found. And in a small cohort, we can show that they've had viral myocarditis. This is a study looking at patterns of late gadolinium enhancement in non-ischemic dilated, sorry, that should be non-ischemic dilated cardiomyopathy. Idiopathic dilated cardiomyopathy. And they looked at 185 patients and separated them according to late GAD negativity, which is 112. About 40% had late gadolinium enhancement, of which there were some that had the typical diffuse mid-wall pattern, but there were 3 other types that they described: epicardial, patchy, and sort of rather diffuse transmural. It's tempting when you look at these patterns of scar to think, well, actually, these look rather like acute myocarditis patients, and presumably these therefore reflect the end stage of an acute myocarditis. Actually, no one has managed to show a direct causal connection as yet, except in a few patients. So whilst it's tempting to say, well, this must be related to previous myocarditis, we don't know that. What we do know, however, is that the pattern and extent of scar is related to outcomes, and if you've got late gadolinium enhancement, you do less well than if you don't. So I hope what I've shown you during the last hour is that both cardiac morphology and tissue characterization are essential to the diagnosis of the dilated heart. Cardiac morphology allows us to identify structural heart disease, occult shunts, etc. Whilst tissue characterization allows us to interrogate the myocardium itself and look at that second group of causes of heart disease, which is the failing myocardium. Patterns of late gadolinium enhancement allow confident differentiation of ischemic cardiomyopathy from non-ischemic dilated cardiomyopathy and other cardiomyopathies. Tissue mapping, I think, really helps to identify myocardial edema, diffuse fibrosis. And I think will help increasingly once we know more about it in terms of prognostic data. And during this talk, I've really not spoken about prognosis because I haven't had time. I've spoken really about tissue characterization in terms of diagnosis, but there is vast amounts of prognostic data there that we can tap. Right, I've taken a full hour, so well done for paying attention. If people want to, I'm happy to answer a few questions.
So Charles, thank you very much for this fantastic and comprehensive overview. It's a huge topic which encompasses a large series and range of affections from congenital heart disease, ischemic heart disease, cardiomyopathy, myocarditis, so the full range of cardiac MR, and you did it perfectly in 1 hour. So we are ready to listen to the question from the people who are still connected till the last second, meaning that, and confirming how interesting it was for the audience. So please, colleagues, feel free to interact with the platform, to write your questions. Professor Peebles is here to answer and to solve any curiosities or doubts about the topic covered. Let's wait a while to see if there is any question. Marco, yeah. Maybe I can start to discuss with you because I think, well, of course, the focus of this lecture is is cardiac imaging, cardiac CT, cardiac MR. The topic was related to the approach, to diagnostic approach to of dilated heart. And the question I was asking, because it's also our experience and our doubts, how do you locate, where would you locate, and oh my God, a biopsy in this set of patients? When would you recommend it, and do you use it? What's your experience with that? Mainly for, of course, for LV dilations, which is a world.
Yes. So I think that's a really good question, Marco. And the reality is, you may have noticed from the European data that I showed that about 10 to 30% of patients in different cohorts are having endomyocardial biopsy. In the UK, actually, that's much lower. We've been really anti-invasive testing for most of these processes. Why that is, I don't know, but I think we are an outlier in terms of the aggressive way we seek a diagnosis. So I think we're quite poor at this. Having said that, I think the confidence that T1 mapping ECV analysis gives us to diagnose things such as amyloid really will help reduce the number of patients who undergo biopsy. And in the acute myocarditic phase, we haven't spoken about that today, but the ability to confidently show that there's myocardial edema in someone who presents with chest pain, I think makes the requirement of a confirmation with tissue diagnosis much smaller. So I hope that we will be able to reduce the number who require biopsy, and also we will be able to target the biopsy much more effectively to areas of active disease than we could do in the past, because in the past we've relied on late gadolinium enhancement, which of course sends people to areas of scar, but you really want to avoid areas of scar and go for areas of active inflammation. So I do think that tissue mapping sequences could make a big difference to that cohort of patients.
So thank you very much. I totally agree with your answer. We do have one facility doing endomyocardial biopsy. The number of procedures is more and more reducing because of its invasiveness, and because, as you said, the tools of MR are more and more improving accuracy. But what is still also interesting, and this is my second question, waiting maybe a couple of minutes more for raising hands by the colleagues, is related to toxic cardiomyopathies. I know you have also experience in imaging of oncology, lung cancer and whatever. We are also treating very often patients with dilated cardiomyopathy post-chemotherapy or with unexplained causes or toxic causes, etc., which is also a theme and a running pathway we identified for next ESCR. So it's a very hot topic. What's your experience with that?
Yeah, so again, my experience is that mapping sequences are very helpful. Whilst in the literature you see cases with typical lateral wall myocardial scar or more diffuse myocardial scar patterns on late gadolinium enhancement, in our clinical experience we don't see that very often. And actually the ability to show an abnormal ECV or native T1 mapping or indeed edema T2 mapping really allows us to confidently say, actually, yes, there is an inflammatory myocardial process going on, and we can then look for causes, and usually in the context of cytotoxic chemotherapy, etc., we will deduce that that's the cause. So again, I think this is an area where mapping sequences are really going to be revolutionary in terms of the confidence of diagnosis and the differential. I don't know if that's your experience, Marco.
Yeah, absolutely. We started without mapping, and it was really, well, contradictory, because, as you said, late enhancement is exceptional, edema is exceptional. So 5-6 years ago, in the pre-mapping era, we didn't have too many insight from that. Afterwards, with T1 and mainly with T2, as you said, you measure the activity of the process, and you know that there is a toxic process. Of course, comparing and correlating results with clinical data of the patient, you get a lot of intriguing information. So I think this is another direction in which really MR is bringing us in the dilated hearts. I totally agree with you. Yeah. And there is one question for one colleague. Maybe it's 6 minutes past 6, so we should close in 3-4 minutes. But it's Dr. Fabio Domenico Geco, who is asking, do you use MR, time resolved angiography in your protocol in order to exclude and diagnose vascular causes of RV dilation. So the question is about time-resolved imaging.
Yeah, that's a great question. And I think it's very helpful in many causes of shunts. And if we are doing a non-supervised list where there's a question about a shunt, then we will use time-resolved angiography rather than anything else. I think specifically for partial anomalous pulmonary venous drainage, it's very helpful. I find it less useful in atrial septal defects, although it should be helpful. I found it actually, it doesn't help as much as I would hope. But it's part of our routine. So when we're doing angiography, we do time-resolved angiography rather than a standard angiogram, because I do think it's really useful. So I would recommend it if you can. Yeah. Okay, and there is a second question. So you see people are still fully connected. Again, to confirm how interesting it was. It's Dr. Fabian Caius. It's a practical question. What do you do, or what is your conclusion if in CMR there is a mild LV dilation with normal or borderline ejection fraction, no tissue pathology, but an infection a few weeks ago? So I think it's addressing the myocarditis topic. So everything is normal, and there is a mild dilation of the ventricle. How do you approach the problem? Yeah, so there are two answers to that. One is tissue mapping, and I think that's exactly the sort of patient group where being able to more confidently say there is or there is not an inflammatory myocardial process going on at the time is really helpful. So that might push us in a direction of making a confident diagnosis, or it might not. And if we don't, then what we usually end up doing is a follow-up MRI scan in 3 months to look for resolution of the dilatation and function. And if we don't see that, then we will probably think they've got some sort of dilated cardiomyopathy. Hopefully we'll see resolution, and we'll be more confident that they've had an acute inflammatory process. So I think T1 mapping, great, and follow-up MR, really important. Great. You are a mapping lover, as I am, so, and I think it's really providing a new light in the clinical use of MR. So well, interesting, Marco. I should just say that actually I was a mapping non-enthusiast originally. I was quite skeptical about how it was going to be impacted, and I think you're absolutely right. I think we're all converts. Yeah, it was a conversion, like in a pre-Easter era. It's a kind of religious conversion, I would call it. Yeah. So it's 6:10. Still, a lot of people are connected, but unfortunately, we have to close. And really, I know what an effort it is. It will be my turn in September, so I'm scared about it. I was already the moderator in the last webinars, and I know the effort you did. Really, thank you. It was a great honor and a pleasure. And let me announce the 5th webinar from Gianluca Pontone, my friend and colleague from Milan. He's one of the experts of cardiac imaging in Europe. He will talk about MR in cardiovascular implants receipts, May 17th, 2007 at 5. So for those of you who enjoyed, I think most of you are still here, please connect again next month. And thanks, Charles. Thanks to all colleagues, and wish you a nice end of the day. Thank you very much. Thank you, Marco. Goodbye. And of course, thanks to the office, because we got a full support from Ellen and from Wolfgang throughout the webinar and in all our activities. Thank you.